Yeah, you remember, guys, I had told you earlier that we're going to have a masterclass and talk more about endometriosis and how, when it starts, who is at risk, all those questions, we're going to answer them. And I have none other in studio than Dr. Charles Victor Okumu, who is a gynecologist, and he's going to guide us through this conversation, guys. You remember, I hope you have your notebooks, because I don't want you to struggle later and ask me, oh, Ellen, what did you say about that? What should have happened? No. It's a conversation right now. I hope you have a notebook. And we're going to have this conversation. Dr. Good morning.
Good morning.
Good morning. How are you?
I'm good.
Good to see you.
Thank you for inviting me.
Yeah. Now, Dr. Before we start this conversation, it's always our first question to ask, what's your pink, Dr. What's your pink?
Okay.
Yeah.
My pink for this week is a very interesting one.
Yeah.
Yesterday, I was listening to Senator Boni Khalwale.
Mm-hmm.
And Senator Boni Khalwale said that one of the wives has twins.
Okay.
And Boni Khalwale closed Mama into his own house.
Yeah.
And he delivered the twins himself. So it was hilarious. It's a nice thing.
Yes.
It's really hilarious.
Yeah.
Because to have the courage to deliver your own wife of twins.
Yes.
It's nice. He's safely delivered them. But it's hilarious because why? And then thirdly, it's even unethical. And the Boni Khalwale is a medic, and you should have known that it's unethical.
Culturally?
And medically too. But it was nice that it happened. So that was a nice thing.
Oh, that's a good pink. You've made us laugh ahead of this big conversation. And, earlier we were also talking about Bonnie in terms of polygamy.
Okay.
And we discussed the positives of polygamy, because there are some. There's always two sides to a coin,
Yes.
Yeah.
Okay.
Anyway, Daktari, asante sana for being here. And we're going to go straight to this conversation. Understanding endometriosis. First of all, I know there are some people who are just hearing this word for the first time, or they've had it in the last 1-2 weeks when it's been a subject of conversation on social media. So exactly what is it?
Let me clarify one point that many people do not understand.
Yes, Dr.
Menstrual periods come from the uterine lining, not the ovaries, not the tubes. Because sometimes when you say you want to do a tubal ligation, the lady will, but now will I have periods?
Oh.
Because they think periods come from the ovaries.
Yeah.
Then they'll find the tubes closed.
Yeah.
So she will not see periods. No. Periods come from the uterine lining called the endometrium.
Okay.
In the ovulatory age, in the reproductive period, a series of events occurs in the body to prepare for ovulation to occur.
Okay.
Now, those hormonal changes cause the endometrium to thicken.
Okay.
In preparation for the implantation of the fertilized egg. So, if fertilization does not occur, the thickened uterine lining is shed.
Yes.
And that's what the bleeding is.
That's the normal period.
That's the normal period.
Yes.
Now, in endometriosis, this normal uterine lining is somehow transplanted into various areas.
Okay.
The tube, the ovary, the rectum, the bladder, everywhere. So, endometriosis is endometrial tissue outside the uterine lining.
Okay.
Now, why it is a pathology is because when ovulation occurs during the cycle, during the time that the uterine endometrium is being shed, hormonal stimulation causes all those sites to also bleed. So you are bleeding, and by the way, it can go anywhere. Endometrial tissue can be anywhere, including the lungs.
Ooh.
So now you can imagine bleeding within the lungs.
Oh my God.
Every month. So you are bleeding within the uterus, which is normal. You are bleeding within the ovary. you're bleeding within the abdomen, the intestines, wherever there is ectopic endometrial tissue.
Yeah.
Ectopic means in the wrong place.
Yes.
Yeah, so that's what endometriosis is.
Okay.
Yes.
Oh, thank you for that explanation. It explains so much, and I'm sure our listeners understand now the difference between your normal period and what happens when you have this condition, endometriosis. So how common is it in Kenya particularly, and is there maybe data maybe suggesting how many people may be even undiagnosed?
We don't have data. It's not very common.
Okay.
But when it occurs, it is a very severe disease.
Okay.
And we must do the diagnosis because it mimics very many other things. It mimics gastrointestinal symptoms such as irritable bowel syndrome. So you can think, no, mine is because irritable bowel syndrome is also stubborn and on and off, and
Yeah.
So the diagnosis has to be made. So when a lady starts to feel the symptoms, and there are many, but mostly pain. Pain during periods.
Okay.
Pain during sexual contact, pain during defecation, passing of stool, because it I've said it could be anywhere.
Yes, you have.
Now, if you are unfortunate that it's in all those many places, then you'll have very many symptoms. Okay? But one of the big ones is infertility.
All right.
So many times we make the diagnosis because a lady is looking to get pregnant and she's not conceiving.
All right.
But there are many pains. Now, another complication is initially these pains are cyclical.
Okay.
It is during the bleeding period. Okay? But now, blood causes a chemical reaction with the surrounding tissues. So that causes scarring of the tissues.
All right.
That causes adhesions where one organ attaches itself to the other, the bladder, the intestines, what we call the omentum. So once these things get adherent together because of scarring, then now you get chronic pain.
Yes.
Which is there whether you have periods or not.
Yeah.
Yes.
Okay.
So because then somebody said, no, since mine is not cyclical, it cannot be endometriosis. It could be. Yeah.
Okay. So apart from that pain during the menstrual cycle that is extreme and very extreme, are there maybe other significant, symptoms of the disease?
There are very many.
All right.
Okay. We said menstrual cramps, painful periods, painful sexual contact.
Yeah.
Lower backache, abdominal pains, abdominal bloating, diarrhea, constipation, blood in stool. Because, as I said, when this endometriosis becomes like a small ball, we call it an endometrioma.
All right.
So this endometrioma could sit in the rectum.
Okay.
So that during that bleeding period, you will now get blood in stool.
Oh, wow.
And you wonder what is the relationship? Yes, you have an endometrioma sitting in the rectum.
Okay.
You get vaginal pain. You get vulval pain. You get pain during intercourse, pain during even penetration, bladder pain, pain with urination, blood in urine, urinary agency where you can't hold urine.
Okay.
Then, of course, when it is like prolonged sitting, like people sit, you get pelvic pain, prolonged sitting. Then, of course, infertility.
Okay. You're describing a very unfortunate experience for women, And even before I talk about the diagnosis now, there is a sister to endometriosis that you had mentioned too.
Yes. The younger sister to endometriosis is called adenomyosis.
Okay.
And it would be unfair to the viewers to discuss endometriosis without touching adenomyosis.
Yeah.
Adenomyosis is an endometriosis within the uterine wall only.
Okay.
That's why it's a younger sister, because it has fewer problems than endometriosis. So in endometriosis, the ectopic endometrium is anywhere within the body.
All right.
In adenomyosis, the ectopic endometrium is restricted to the uterine wall.
Okay.
Yes. So it has similar, very, very similar symptoms, pain, very, very, very heavy bleeding, pain during sexual contact, and again, also infertility. So sometimes people endure these other things, and we only make the diagnosis once the client comes with inability to conceive. Yes.
Okay, Dr. So let's talk diagnosis. What actually is the diagnostic process for this sick ailment?
The diagnostic process we try is very complex. We try, of course, normal clinical examination, because if you have an endometrioma in the vaginal canal, you will see it on digital examination. Okay. Or if you do a speculum examination, you will able to see it. Okay. An ultrasound will show us also. There are specks here and there, and of course they are severe. In fact, endometriosis is staged from stage 1 to stage 4. Stage 4 being the severest. Okay. So an MRI, magnetic resonance imaging, will show us where it is, but the definitive diagnosis on laparoscopy. Laparoscopy is where you are looking inside the abdomen through small holes. Okay. And light, so you can see it. So laparoscopy is both diagnostic and therapeutic, because if you are looking at it and you see the various endometriomas, you can remove them surgically using laparoscopy. So it's both diagnostic and therapeutic. Okay. Yes.
Well, we are talking about the diagnostic process for you. Is surgery always necessary? Is it?
Yes and no. Yes, because it can relieve the symptoms. Okay. And no, because it could be so, the distribution could be so diverse that you can't remove everything.
I get it. Like when you're saying it could be on the lungs, all this.
Yes. Yes, then you need lung surgical lung specialist to, depending on where it's located, be able to remove that. Then it's rectal, then it's on the bladder, then it's in the vaginal canal, then it's within the intestines. So one. Secondly, there might be even smaller ones that you are not seeing at the time of removal. Oh. So it's really complex because it is cumulative. When I say an endometrioma, it's now a tiny ball. It has accumulated because this monthly stimulation with the hormones causes it to also multiply and grow. Yeah. Okay. So there could be tiny ones that have not yet grown. Oh. So you go in, you say you have removed, there's a little bit of relief. But then you find later on that the symptoms have recurred. Yes.
Okay. All right. Thank you. So let's now get to treatment, Dr. Once someone has been diagnosed, what are the treatment options that are available?
If we are lucky and the symptoms are mild, we just treat them on analgesia, the normal painkillers, spasmodic, and if they don't have adhesions at that time, then the pains are cyclical. So if those few days per month, if you get a combination of good analgesia, then people can live with it. Now, if that does not work, then we put the patients on hormones that restrict ovulation.
Okay.
Because if you do that, then the endometrium does not grow and you don't get that cyclical bleeding because ovulation has not occurred.
Okay.
So it is sitting there, but they are not either less symptomatic or they are not symptomatic at all. Okay?
Yeah.
Now, these symptoms subside at menopause.
Okay.
Because now you are not ovulating.
Yes.
I say subside because if you have already caused scarring and adhesions, then you are already at the stage where you are having pain outside period time.
Yes.
So those pains will continue to be there.
Okay.
Even after menopause. So, because menopause causes an improvement, we can create a medical menopause where we cause your ovulation to cease at this point. Temporarily, we can reverse it later.
Okay.
But for now, you are not having periods at all.
Yeah.
But now, if we do that, if we cause medical menopause, then you have all the symptoms of menopause.
Oh, wow.
including hot flashes and night sweats and thinning of the bones, all the symptoms of menopause.
Okay.
Which could be just as nasty. Now,
True.
if you can say, okay, let us give hormone replacement therapy.
Yes.
Okay, like we sometimes do in menopausal women. But unfortunately, if you do that, then you stimulate. Okay, you are trying to control the level of estrogen because that's the main hormone causing the symptoms.
Yes.
But still, you will resuscitate a bit of the discomfort. So it's very difficult to calibrate so that say, no. Your HRT, hormone replacement therapy, is removing the monopolal symptoms, but now reviving the endometriosis symptoms is not as severe. Yeah, so that's the dilemma. It's a difficult problem to deal with.
Yeah, it seems so.
Yeah.
When you're talking about hormone replacement, I think what is coming out clearly is whether, in terms of treatment, is where we have hormonal treatment and surgery. As a doctor, how do you determine which one maybe, or is it age of the woman? Does that matter?
You discuss, you put all the options on the table.
Yes.
And it is up to the client or the patient and her family or her partner to say, let us go for this. Since it's not a cure, you cannot say dogmatically, let's go for this one. Because if we don't do that, and then some symptoms persist, then you will come for me.
Yeah, I will. So it seems like we're just managing the symptoms here. So in the fairest of ways, according to the patient, is how you look at it.
And we can only hope that we have caught it early.
Yes.
Like I said, there are 4 stages. Stage 1 is just a little bit of it. Stage 2, it has extended a little bit. Stage 3, it has gone. It's in the ovary. It's in the pouch of Douglas. Pouch of Douglas is an empty space between the uterus and the rectum.
Okay.
And in stage 4, it's everywhere, and there are extensive adhesions. So when we are in stage 4, it's a nightmare scenario.
Yeah.
But when we are in stage 1, then these maneuvers can cause substantial relief.
Okay.
Yes.
Someone is asking me to ask you if it can come back after surgery.
Yes, I did mention earlier that we are removing what we are seeing macroscopically. There are little things sitting in there. So the only way we can remove is if we remove the uterus kabisa and then remove the ovaries. Then, of course, we have precipitated menopause straight away, even if you are 30 years old. Then we go to hormone replacement, and the little ones that we didn't see become reactivated, but that symptomatology is much less severe than. So yes, we can. It can recur or it can persist.
Wow.
Even after removal of the uterus and the tubes and ovaries.
Okay.
Yes.
And I'm also getting a question whether there is any role in the pain management that maybe exercise and nutrition could assist in.
Absolutely. Lifestyle changes and exercise, and they are all there. Yes, they're extremely important.
Yeah. Okay.
Yeah.
Now, you had mentioned earlier the effects of this ugonjwa, endometriosis, on fertility and pregnancy, chances for women. And I think maybe we can dive kidogo into it because it's obviously a very heavy burden to carry because of something that is uncontrollable. So maybe we can, obviously you've mentioned that endometriosis is often associated with infertility.
Yes.
So does it actually mean that, as you're saying, one of the solutions is surgery, meaning you're eliminating the chances?
Okay. We can do, like I say, in that laparoscopic surgery, one of the causes of infertility, again, is quite complex. We think that this scarring of the ovary might interfere with proper ovulation. Adhesions might distort the positioning of the tubes, and because the egg must leave the ovary, it must find its way into the tube where fertilization occurs. Then it progresses into the uterine cavity and it plants itself in this endometrium that is thickened and properly chemically constituted to receive the egg. So we think that sometimes you can't conceive because of the distortion of the tubes and the scarring of the tubes, because the tubes have fimbriae. Fimbriae are fingers which grab the egg. So if those fingers are not functional, then we might not grab the egg. If the egg has managed to exit from the ovary. But if the ovary is scarred, the egg might not even be able to escape. So, with the surgery that does not include hysterectomy, we are doing surgery for fertility purposes, then that adhesiolysis, removing the adhesions and recalibrating the configuration of the tube and removing any adhesions around the ovary, that will lead to conception.
Okay.
Yes.
So there is a chance, kidogo.
Yeah, there is a chance.
And also maybe it has to be in the earlier stages as opposed to stage 4 and Okay. And maybe as a doctor you can advise in a kind way. There are obviously people who maybe are in the very late stages of this endometriosis and they still want a chance to have children. Maybe they can seek other options of...
Yes, IVF has a chance.
Does IVF help?
Absolutely. IVF is, in fact, in situations where we are causing medical menopause, we can harvest the eggs, store them, cause medical menopause, wrestle with the treatment, and when we think we have reached a stage where we can reintroduce the egg, we can cause the patient to become pregnant.
Wow, that's the silver lining. That's very good.
Yes.
There's hope.
No, you see, it's not that gloomy. Let us revisit adenomyosis for 1 second, because adenomyosis, the treatment for adenomyosis, first of all, the diagnosis. Adenomyosis is very difficult to diagnose. So again, it is clinical examination where the uterus is soft and enlarged. Then there is ultrasound and MRI. But now, the definitive diagnosis that this is adenomyosis is histological. You can only do that after hysterectomy. So you cannot do it for a person who is in the reproductive age and desirous of children. Okay?
Yeah.
But if, unlike endometriosis, if you do total hysterectomy in adenomyosis, then it's cured. It's not there.
Yeah.
The pains have gone because they were limited to the myometrium.
Yeah.
They were limited to the myometrium. And another good thing, that's why it's a younger system of endometriosis, is that you don't have to remove the ovaries. Yeah. So you remain with your premenopausal or normal reproductive age features.
Okay.
And yet the pain is gone. But of course, the disadvantage is that then you cannot have children.
Yeah.
Now, fortunately, the risk factors for adenomyosis is one, age over 40.
Okay.
So it comes later in life. And the theories are that in adenomyosis, there's a little seepage of this normal endometrium into the uterine muscle, which is now an abnormality. And we are saying high parity, having many children, predisposes you to that, because each delivery event is a trauma to the uterine wall.
Okay.
So these endometrial cells seep into the myometrium quietly and sit there. And if you have another baby, then a little bit of it, then another baby, then a little of it. But then, fortunately, if you have adenomyosis because you've delivered 5 times, then we can do a hysterectomy without you being unhappy. Okay?
Yes.
But also, surgery, like cesarean section and diagnostic DNC, any surgical manipulations of the uterus will allow those cells to go into the wall and cause adenomyosis.
Okay.
We also think, again, nothing is in endometriosis and adenomyosis, nothing is definite. But as scientists, we must continue researching and associating with these things. So we also believe that sometimes during embryonic development, some cells become trapped in the wrong place. Instead of being in the uterine lining, they find themselves in the uterine wall and give us those problems again. And in adenomyosis, we also have infertility. And we think that infertility in adenomyosis, because ovulation occurs, the tubes are open, so the egg is able to come. But we think that the uterine wall itself has problems. There is inflammation from this adenomyosis, so that implantation does not occur. We also think that the pre-ovulatory thickening does not happen adequately, so that there is no root-tuber by the time the fertilized egg, because fertilization has occurred somewhere in the tubes, but the root-tuber of the uterine wall is not sufficient to accommodate the implantation of the fertilized egg.
Okay.
Yes. Okay. Go back to endometriosis.
Yes. Let's talk about care, because I feel like, and maybe it's again because it's been on social media in the last several weeks, and I don't want our listeners to assume or think that this is an urban person challenge. So what is the level of access to care for people in the rural areas?
It's poor.
Yeah.
It's extremely poor. This is a complex thing.
Yeah.
Like I said, it resembles like what gastrointestinal thing. There are people with irritable bowel syndrome, for example. So you have had all that in your life. And as I said, diagnosis is ultrasound and MRI. So the moment you mention those two procedures, then the rural Kenya is shut out completely.
Yeah.
Rural Kenya shut out. Okay, so even if you treat on clinical suspicion, then you are limited to a hormonal this and the other. But now, without pinpointing the diagnosis, you might just be treating IBS, irritable bowel syndrome. Yeah, so no, rural access is poor. It is urban, or even if in the rural area, it is equipped facilities, equipped healthcare facilities.
Okay.
And also qualified personnel.
Okay.
Yeah.
I want to ask a certain question, and then maybe you can answer also in regards to policy, because once this conversation was on social media, we saw the Senator Karen Nyamo talking about maybe there needs to be some sort of guidance in terms of even insurances taking up patients and all that. So, in general, in layman's language, how much is this disease going to cost an average Kenyan, without thinking maybe insurance and all that? And then maybe you can talk about governance and policy in that regard.
Well,
is it upwards of 500,000? Is it?
If we go through the whole barrage of treatment up to surgical intervention, it could reach 500,000.
Wow.
But an ultrasound in all institutions is 10,000 and below.
Okay.
MRI, 40,000, 50,000.
Yeah.
Okay.
Yeah.
Then now we go on to hormone if we want to remain there.
Yeah.
But once we go to theater to do laparoscopy and look inside, then we are already up to 250,000 shillings talking.
Wow.
To just look. But if we sit there performing surgery, we are already past 500,000.
Okay.
So it's an expensive procedure.
It is very
extremely expensive procedure.
Can you talk maybe insurances? How can policies come up that could support women going through this? Because
according to me, the normal insurances do a good job.
Okay.
They cover this.
Okay.
The only problem I have had myself, and I've not understood why, is SHA. Because I don't want to say whether it works or not.
All right.
But where it works, the allocation for these procedures is like 30,000.
Wow.
So 30,000 is just an ultrasound.
That's just an ultrasound.
Yeah. So I don't know why I've not sat down to study how it can be improved.
Yeah.
Because they should say if you do this premium, then your allocation will be this.
Yeah.
But now they calculate for you, you pay for a year, then you go in and you are told 30,000. In fact, most of the patients that I have had, when you go to the employed people, somehow it reaches about 90,000.
Okay.
But now every Kenyan has entered. I hear the president say we are now 30-something million.
Yeah.
But now, if the majority, the allocation is 30,000, it's totally not useful. It's totally not useful. But the other insurances cover this very well.
Okay.
Yeah.
Okay.
Yeah.
Okay. So, you mentioned workplaces and all that, and maybe you can tell us what role maybe schools even and workplaces could play in supporting women living with endometriosis. And on that note as well, maybe you can highlight, are we doing enough to create awareness and improve access to healthcare, nationally, particularly in regards to this?
Endometriosis and even adenomyosis ni ulemavu.
Yeah.
So, workplaces, anywhere where these people are engaged, they should be, we should be able to recommend what they can do and what they cannot do. And then the employer should be sympathetic instead of saying, but if you can't do this and you are the category X of employees, then we can't have you. But yes, it is debilitating completely.
It is.
There are patients whom we have to admit during those 4 or 5 days, just to sedate them because the pain is too much.
It's too much.
No painkillers are working.
Wow.
So you knock them out.
For a whole 4 days.
For a whole 4 days. They are sedated.
Yeah.
They are not dead, but they are non-functional. Yeah. Then again, you win them off. So they need to be, it should be categorized as a disability. Ulemavu kabisa.
Okay. Now,
One question again I'm getting from a listener. Can it be prevented? No, because we don't even know the cause. We don't know the cause. I did endometriosis. What we have, the research has shown that it's, as I say, we believe, for example, I didn't talk about that, is that one of the causes of endometriosis is retrograde menstruation, where you when this endometrium is breaking down, instead of coming out through the vaginal canal, it goes into the tubes and it travels back and it enters the pelvic cavity. Yes. Then it starts to create those two endometriomas that I talked about. Yes, Doctor. So, how you can we can this one so it's very, very, very difficult to prevent. Another thing is that it is also familial but not genetic. That means that if your mom had endometriosis, you are likely to have it, but not because there is a gene. No, in genetic transmission of things, there is a particular gene that causes you to get that, like sickle cell and albinism. There is a specific gene where we can prevent by saying, you don't marry this one. If you combine, you'll produce a sickler or somebody with albinism. Okay. In this case, we have not found a gene. We have just found an association. So we are saying, well, it could be the environment because you are living in the same environment and all that. So no, we can't prevent. We can only diagnose as early as possible. As early as possible, at stage 1. And does having endometriosis mean a woman has a higher risk of cancer? Some literature say there's a remote chance, and some literature say no. Yes, so it is not conclusive. Yes. So there's no conclusive. It's not conclusive. There is no strong association, let's put it that way. Yes. It seems like it's such a big and mysterious disease. That it is a mysterious disease. It's very mysterious. And yet it's going to take away from you literally. You could even be sedated for 4 or 5 days. Oh my. Anyway, it's a very sad situation, I would say. So, but the only good news is that it's rare. It's rare. You also mentioned that it's quite rare. It's rare. Yeah. Okay. So, if I walk into a hospital today, what specifically should I ask a doctor if I suspect that I might be having endometriosis? What, as a patient, what should I ask the doctor to check out for? Well, you go with your discomfort. My discomfort from the symptoms that you're talking about. Doctor, I have 1, 2, 3, 4. Some patients is going to say, Daktari, niko na malaria. Okay. Let me conclude with the causes that that's why it's difficult to prevent. We are saying that sometimes this endometrial tissue just travels through the lymphatic system, the same way you get cancer spreading. Cancer spreads through the body channels, the lymphatic channels to distant places. So we are speculating some of it just travels through those channels and goes to those places. Okay. Some theories even say that no. It is the cells that are sitting there near the rectum that undergo a metaplasia, which means they just change from normal rectal tissue to endometrial tissue. So once you have such diverse possibilities, it's impossible to prevent. It's impossible. Okay. We have about 2 minutes, but I hope, Dr. maybe you can give us, you can leave our listeners with a message on endometriosis, maybe
and encourage those who are even going through it.
Yes. The good thing that is rare, I think that's a positive message.
Yes.
It is rare.
Yes.
But if you have pain, and again, painful periods are very common.
Yeah.
Everybody has painful periods.
Yes.
But if you think yours is a little bit more severe than other people, seek medical opinion.
Yeah.
Okay. If you want to go there and say, I think I have endometriosis, go and say, yeah, but severe dysmenorrhea.
Yeah.
No, we should evaluate you.
Yeah,
we should evaluate
there's
you.
a problem.
Yeah, and as I said, some people, they have these severe pains from day one of periods. So now we just that one has this dysmenorrhea more than other people, but we need to evaluate. So yes, if you think your pains are more severe than other people, than your peers, let us have a look. Let us have a look, because if it happens to be endometriosis and we diagnose it early, it is better managed.
Yeah.
But it is very, very rare. And again, for some people, the symptoms are so mild that their first visit to the hospital, to the doctor or the clinician, is because they are not conceiving. So again, even if you don't have severe symptoms, but somehow you are not conceiving, and by definition, if you must cohabit. For you to be infertile, you must cohabit. You must live in the same roof with your spouse.
Yes.
Some ladies, mzee anafanya lokichogyo, comes once a month when ovulation does not exist. Then she says, now I am infertile.
Yeah.
Okay? So you cohabit continuously for about 3 months. Then say, you must ask us why you are not conceiving.
Okay.
Okay? Then the investigations are quite easy.
Yes.
Yeah.
And then the diagnosis, and then we start the treatment.
Yeah.
Okay. Well, that was our masterclass. We have spoken about endometriosis. I hope you now understand it better. I hope you can help a sister, a friend who could be going through this, and you can advise them that when the period is extreme, there's a reason to go see a doctor. We've spoken to Dr. Charles Victor Okumu, who is a gynecologist, and thank you so much for taking us through that masterclass.
Thank you for having me.
Thank you, Dr. Harry.